excited to talk about the Transkambin lumbar fusion, or the OptiLIF, or whatever you want to call it. Honestly, this procedure has really changed my practice. I've been in practice since 2013 in private practice. I do mostly degen spine, and do pretty much all the typical approaches, ALIF, lateral, TLIFs, etc., and do, MIS surgery to deformity correction. So really think that the Transkambin approach has modified my practice. So I've been doing it since 2016, and it's quite an interesting procedure because it's super easy, super minimally invasive, and really has a variety of different ways that I think it can benefit your practice, anywhere from just your standard single level lumbar fusion cases to complex deformity and even revision surgery that sometimes can be extremely challenging. So excited to just kind of introduce this procedure to you. Transkambin approach is a little unique in that it is a little intimidating because it definitely is a different approach, and not something that we're really used to. I would call it more of a lateral approach, but it is posterior to the, or I guess in the anterior column. So you're coming anterior to the facet joints, but posterior to the nerve root through the Cambin's triangle. And if you do any endoscopic surgery, it's a very similar targeting approach that we use to get into this area. And believe it or not, even in the most bone on bone discs, it's pretty easy to get into because you just have to introduce a guide pin. And once you get the guide pin in there, it's very straightforward. So the portal itself that you do all your instruments and the discectomy through is 7 millimeters. So those diagrams there shows the average size of Cambin's triangle and where the portal would fit into that disc space. But basically by the exiting nerve root and the traversing nerve root. And then you've got your inferior end plate that is the inferior border of the triangle. So targeting, I think if you've ever done endoscopic, it's very similar. But targeting, I think, is really the most challenging thing to the procedure. And once you understand how to get there, everything else is a routine. Besides instruments being a little different, it's pretty routine disc prep and interbody insertion that you would do for any fusion. So I usually take an AP x-ray, and like the diagram says there, just kind of mark out your inferior end plate of that disc space. And the training tools say measure pedicle to pedicle, and then you'll go that same length offline. Honestly, it ends up being about 8 centimeters offline, off midline almost every time. So I go 8 to 10 centimeters offline, depending on how the body habitus is of the patient. The bigger the patient, the usually a little bit more lateral you'll go. But this technique also works very well. But so you'll go about 8 centimeters off midline, and then that will be your incision and entry point. And it says make a centimeter incision. I mean, the portal is only 7 millimeters. The distal end of the portal is a little bigger, so 1 centimeter is pretty generous. I mean, you don't even have to really make an incision that big, which I think is the beauty of this procedure, as it really is placing the spacer through a teeny incision. But you'll go navigate to Cambin's triangle with neuromonitoring. So that this picture kind of depicts the neuromonitoring probe that comes in the set. There's a second one that's a little different too, if you have trouble using this one, but very similar to like a first dilator that you would use in a lateral. But you'll target the entry to the Cambin's triangle and then stem to ensure that you are not super close to the nerve. I usually stem at 5 and just make sure I'm not getting any 5 milliamps, not sure I'm getting any feedback there. And then you can introduce that into the disc space. So this is how it'll look on the AP x-ray. You can target the middle of the disc space. This particular picture is showing at the bottom end plate. In a big juicy disc like this, which we normally never operate on, you might want to target more midline. But the point is you just want to be as far away from that exiting nerve root as possible. And the lower you are in the foramen, the further away from that nerve root you are. So this is a very safe point, and you want that first entry point on the disc space to be somewhere within the lateral border to the medial border of the pedicle. You just don't want to be obviously medial to the medial border of the pedicle to make sure you're not in the canal as a starting point. But this is the perfect starting point, which is on the lateral edge of the pedicle, inferior part of the disc space. And then at this point, assuming that there are no problems with neuromonitoring, you would introduce the probe into the disc space. And typically at that point, I would do a lateral x-ray just to confirm, like this picture shows, and then introduce that dilator. And then you'll typically place that 50% into the disc. And if it's 50% on the lateral, it's 50% on the AP, or dead center in the middle of the disc. And that is the most perfect positioning that you can really get as where you would introduce your portal. So at that at this x-ray, you would then introduce the second dilator and then the portal, which is shown in this picture. So it's just 3 steps. And then once, like I said, once you have this portal in, it's really easy peasy from there. So since you are coming in oblique, the distal end of the portal is going to look like an oval, and that trailing edge, you want it about 5 millimeters recess into the disc space. So you're safe, you're, a few millimeters in. So when you do deploy the implant, it is receding into the disc space. So once you have the portal like this, you'll take out the second dilator, dock your portal down to the skin, and you're ready to begin the disc prep. This is an animation that just kind of shows you how this looks 3-dimensionally. It's kind of a cool animation video, but that just shows you Cambin's triangle, how that is in relation to where you would go through the skin. It's the first dilator, the neuromonitoring probe is the white one, and then the second dilator, and then the silver is the portal. There is a quick track that usually goes over the skin to kind of hold it into place. And once you have that and the portal is in, it's all the nerves are nowhere near where you're working. So you're pretty much safe to proceed with all the further parts of the steps. So there's a series of different tools in the OptiLIF set that will help you evacuate the disc. So the first step is typically this drill, and that will help you just kind of ensure, measure the size of the implant. So while you're doing your disc prep, the surgical tech could be loading that implant on the back table. So you'll drill this all the way across the disc space. And then there is a measure on the portal that will tell you how deep you are to gauge whether or not you need a small, medium, or large implant. And then the other, I think, Mike, there's some other, yes, the next step is typically the shaper, which is basically goes in at 7 millimeters, and then you'll slowly dial up that shaper. It's very similar to how a TLIF shaver looks. But it'll slowly open up, and you can spin it clockwise to morselize the disc space. And then you can open it to size to see to see how much disc you need, and you can kind of feel there's good tactile feel back of when that's peeling that cartilaginous end plate off. And usually in a very normal disc where you have a convexity at the center of the disc, you can open it a little more in the middle so you can really decorticate the center of the disc and close it down when you're a little bit deeper into that lateral edge of the disc. So that's usually the second step, and there's pituitary. So I'll usually place pituitary in, pull out some disc remnants. There's some articulating curettes that are in the set, forwards, backwards, different sizes. It'll also help you peel off that end plate. And then this instrument right here that is pictured, it is the tissue extractor brush. Almost looks like a wire grill brush, if you want to think of it that way, but it's got a little bend on it, and it really, really helps evacuate that disc. So you'll place it in there with the striker, like a striker pie driver. It goes on And I just spin that little thing around in the disc space, evacuates all the disc, and you get a extremely great disc prep. And then the last step would be the verify balloon, which is kind of similar to like a Kyphon balloon if you've ever used that, but it's just got contrasted dye in there, so you can place into this space and inflate it to see how much disc is gone. This is showing the absolute perfect discectomy because you got clean end plates. But if you did have a little ripple effect or somewhere, you know, there's a piece of disc that's still remnant in there, and you can do some more work until you get it looking like this. And at times, if you've got a patient with kind of maybe not the best bone, you might even see a little violation of end plate. I wouldn't worry about that too much as long as it's just a small little minute implant violation, because the implant will really kind of shape to that size. And what's great about this implant, in my opinion, is that, you know, even I've never, I think it just kind of fills all the three-dimensionally crevices of the disc space more so than a triangular implant. And I don't really see much subsidence of this implant. I think it's just because of that reason. It really does kind of morph into the end plates like an implant should. So just another animation video showing the portal in place, and then this shows the depth drill that I said was the first step that helps you measure. Second step would be the shaper. So that's just kind of showing you morselizing another path, then the articulating curettes, and you can even wand the portal back and forth to allow you to reach even deeper than what some of these instruments can do. Then the backwards articulating curette, which will help you really evacuate the proximal part of the disc, which is an excellent instrument that was added in the 2.0 set. And that just shows, you know, almost like an ALIF size discectomy through a 7mm portal. And the more you use these instruments, the more comfortable you get. And it really, really will give you an excellent disc prep for this procedure. So once you've done with the verify balloon, then the implant goes in. It is initially a collapsed just mesh bag, and then there are pre-filled tubes of DBM. You can place sentinel graft, which I believe most surgeons do. In my practice, because it is an anterior approach, I will place BMP. I'll use an extra small BMP or a very small piece of infuse through the portal after I do my disc, right before I place my bag. So I'll place that little infuse anterior, and then place the bag, and then backfill the bag so it expands like this. And then you have your implant in position. And then depending on the size of the balloon will depend, the size of the implant will depend on how many bags you will fill. There's a minimum and max fill, and a lot of the placing the bone graft is on tactile feedback. So this just shows a video of placing the bag, and then after you deploy the DBM cancellous allograft. And I didn't really understand how much indirect decompression you can get out of this implant until I really started utilizing it. It is really impressive how much indirect decompression, and I can show you hundreds of pictures of cases I've done where you'll get just the most amazing indirect decompression from this implant. And then over time, I love that last little picture it showed of just the way that you'll get formation of bone across a fusion and ankylosis across the disc space over time. So that's a CT showing, I don't know how far that particular one is, but I would say that's at least probably 12 months out. And I'll be honest, like initially when you get, I'm an over imager. I think it reassures me if a patient has some postoperative pain, obviously like not right off the bat, but if someone has some pain that they're concerned about, I image a lot just to kind of reassure myself, reassure them, and make sure, you know, they think I'm taking their complaint seriously. But I've seen a lot of CTs, I guess is my point. And initially at that 6-month mark, 3 to 6 to 9 month mark, you will get a little bit of resorption around the bag. So you may not see the integration into the end plate like on this scan. And that's normal because the way bone, this is not a titanium implant. This is a allograft bone implant. So the initial formation of bone is that you'll get some osteolysis of the bone while you're forming calcification of around the newly laid bone. So I usually do not get concerned about any haloing around the implant unless it is persistent beyond 12 to 18 months, or if I start to see gas around the bag or something like that later on, beyond that initial time frame. I have seen some, maybe 2 cases. I've done probably 500 or more implants. May have seen 2 where I've had significant osteolysis of the implant that needed a second surgery, but I think the complication rate is tremendously less than the traditional cages that I have used in the past for TLIFs. And I wish I had given Mike some of my, even 24, 48, got some 4-year patients out, and just even the maturation of the implant over time just continues to get more and more bone growth to the point where almost you can't even discern that there is even an implant anymore. And you'll just get solid bone growth across the entire space. And it really is quite impressive. This is just the data on the trial that was submitted to the FDA when it recently got FDA approval for interbody use. And that showed the data that's presented there. So I think selecting your first patient is important. I think this is a new procedure, and if you're not used to that approach or the targeting, picking a slam dunk case is very important. Initially, not even your first case, but the first 5 to 10 cases, I would just make sure it's a very simple case so you can learn and build yourself to succeed, because doing a challenging case may be somewhat discouraging if you're not able to get the outcome that you want. So I think I saw a question come up a minute ago, but I only saw a very snippet of it. So.
Yeah. Thanks, Dr. Grunch. Dr. Chua wrote a question in the chat, and Dr. Chua says, what percentage of your posterior fusion patients are you able to use this technique without being able to do any direct decompression?
So I think without doing direct decompression. So I would say that it really depends on a multitude of things. Like somebody with severe stenosis, I wouldn't rely on an ALIF lateral or an OptiLift to really do it alone. I think the same type of cases that you rely on indirect decompression, you'll get the same kind of outcome from this implant. But those moderate stenosis, or maybe patients that have radicular pain only when ambulating or weight bearing, and patients that don't have pain at rest with mild to moderate stenosis, are the ones that I really rely on the indirect decompression, or maybe just have radicular pain periodically. But it really is a pretty easy procedure, at least in my practice. I'll drop the Optimesh bag down, the screws, rods, and then drop a metrics tube down at the end and decompress if I need to. So it doesn't really add a lot of time, maybe like 30 minutes if I need to decompress. So yeah, hopefully that answers your question.
All right, I'm going to go to some of the surgeons that could not attend tonight, some of their questions. So the first one is achieving lordosis in maintaining or restoring sagittal balance. How do you achieve that with the approach and with the Optimesh implant?
That's a great question. I think that what you'll see, because it is a implant that kind of conforms to the disc space, a lot of surgeons have that concern. Well, how am I going to restore coronal imbalance, sagittal imbalance, get lordosis? And I think, because it does conform to this space, you'll get the ligaments will stretch and realign to their natural lordosis space for the most part. If you have someone that's in a extreme kyphosis of a disc space, or really needs a, 20 degrees or more correction, this is probably not the implant that you want to use. But for just restoration of natural lordosis, it's intrinsic within the disc space itself. Almost every time I'm able to achieve that. And it is a little bit different of an approach. So it is because it is sort of a malleable type implant, it's more of an art, I guess is how I would say it. So if I want to achieve a lot of lordosis, I'll place the portal a little deeper so the implant is deployed more anterior, and I'll be able to blow up the bag pretty anterior so I can collapse down posteriorly on my screws in order to get the lordosis that I want to achieve, so the implant doesn't just kind of spread out across the whole disc space. Or on the same token, if you're trying to get a good coronal balance, and let's say the disc is really collapsed on the right, but the left is very tall, I'll really try to place the portal so I can access and place the implant more off to that right side to get coronal imbalance. So it is something that's pretty easy to do. You just have to really be have an open mind and an artsy kind of mind to really make sure you place the implant where you want. And the more experience you have with using the implant, it really becomes very easy to do that.
All right, thank you. I'm going to go with another question from a surgeon out here in Arizona. So achieving fusion, assessing fusion, how do you, kind of look at the fusion? What are they? So it doesn't incorporate, the fusion doesn't look like your typical fusion. What do you?
Yeah. So, for most surgeons, I think that monitor fusion with their patients usually get periodic x-rays. So at least in my practice, I'll get an immediate post-op x-ray. I'll get one at their first post-op visit, 3 months, 6 months, and 12 months, and even, 18 to 24 months if they're having any issue. So I do get a lot of films just to kind of monitor that status. And so how a titanium cage looks is you just look for subsidence, you look for hardware failure. Sometimes it's very challenging to see really bone growth across the fusion, across the disc space itself, until later on where you get bone growth around the interbody. But and even at times that can even be challenging. So you're really just kind of looking at the implant itself. But in this, it does appear to be very different. I mean, you're not going to see really, you're going to see like this hints of bone graft in the disc space. So it does look different. And I also use this implant for vertebral compression fracture. So we also can see it in a vertebral body the same way. But essentially, that first x-ray, you're going to see a very dense bone because you got highly compacted allograft. It's not going to be nowhere near the density of, say, a titanium case, but it'll look more like just a bone graft within the disc space itself. And then at your 3 and 6 and even 9-month x-rays, if you get 9-month x-rays, you may even see a little resorption, like I mentioned, and that's very normal. As long as you don't see any collapse of the disc space. And it's interesting because even though you're getting resorption of the disc space, you're not getting any collapse, and that's because there is bone formation that's happening. It's just not calcified bone that's being laid down yet. And then at that 12 months x-ray, you may start to see more integration within the end plates. Again, it's sometimes very hard to see on a plain x-ray, but you can definitely see it on CT. And then 18, 24, even 48 months out, the ankylosis even continues on, and it can be quite robust. If you place that sentinel graft, that may be the first space to see the integration of the bone graft across the disc space. So in my patients, usually I'll first start to see that ankylosing across the anterior part where I had laid down the BMP. And then I also decorticate posteriorly at the facet, so I look at that as well, but that's also hard to see.
All right, thank you. Next question is pertaining to the disc prep. So I don't feel that I can achieve a thorough enough disc prep, even though, Mike, you told me the new instruments help me achieve that. I don't believe I can get a thorough enough disc prep.
So that is definitely different feel and a different approach to what a traditional disc prep is, because normally you're used to seeing it like if you do a lateral, like looking down the tube, ALIF or a TLIF, where you're, where you're actually visualizing your and feeling, your decortication. But this is the same thing, you just can't see. So it's all tactile feel. The instruments are very easy to use, and it's totally different. So some surgeons aren't going to be comfortable with that because they're just used to the way they're traditionally doing the disc prep. But I think the instruments in the set honestly give me more confidence of doing a better disc prep than what I can do on a traditional TLIF. And I can achieve the discectomy of what I do on an ALIF or a lateral through that small little portal by wanding the instruments and really utilizing the instruments that are designed in the set to give you an excellent disc prep. And the best part about it is that really that confirmatory last step with the balloon, because it really will show you what you have. And it's quite humbling sometimes to put that thing in there and think that you've done the best disc prep in the world, and then to show you that you hadn't. And I've also used the Verify balloon just on regular disc, not even OptiLift sets, just to kind of give me an idea. And it's the same thing. It's quite humbling when you really think you do a excellent disc prep, and then turns out you really haven't. So I think all the tools that are in the set will really give you confidence to do that. You can achieve a very thorough discectomy, much more so than what you would get, which is a traditional TLIF. So.
And then the last question that I have from attendees that couldn't attend, ASC versus inpatient usage. Are you performing these procedures mainly on an inpatient basis, outpatient basis?
Both. So in my opinion, like really this is the most best use, I guess, of an interbody fusion in the outpatient setting. I do them at my ASC and send patients home the same day with the less tissue disruption. And, even if I do a decompression, these patients just do so well with the use of Exparel. And I also place epidural steroids and fentanyl or Duramorph. And they really don't have a lot of pain. Because you're not really doing a lot of bony work. You don't have to do that, taking down the lamina and the facets and stuff. There's not a lot of bleeding. And so they really don't get a lot of pain from this. So I think it does shine in the ASC setting more so than any other implant on the market. But on that same token, I mean, I use them all the time in my deformity and scoliosis cases. So, if I have a patient that I'm doing a tend to pelvis on, I usually do ALIFs at 5'1", just because that's my go-to, and even at 4'5". But if I've got a coronal imbalance or a sagittal imbalance, I can throw in, an Optimesh at L1, 2, 3, 4 in 45 minutes, 3 interbodies to give really great anterior column support and strength to the construct. So I use it in both settings is a short answer.
Thank you. One last question came in. So for spondies, what's your cutoff?
Probably a grade 2. I mean, these aren't hard in grade 1 spondies at all. I get great reduction of grade 1 spondy. It can be challenging just to introduce a portal with that nerve root being pulled forward in a grade 2. I've done it, but it can present a challenge. And I really, I think a good grade 2 spondy needs an ALIF or a lateral probably anyway, just to get good. Those are just bad cases all the way around, which are really uncommon, but I think those are very unstable usually too. So I just prefer to not use Optimesh in those cases. I will say also too, just to kind of keep in mind, I mean, these are not your kind of cases that you want to start using the OptiLift on. But I really also think that this is one of the best implants to supplement a pseudoarthrosis. So it's probably one of my favorite applications if you've got a patient that had a TLIF, and let's say they have an interbody off to the right side and they've got a clear pseudo. And what do you do in that case, especially if it's like 3-4 or 2-3, where maybe you can't come anterior to remove that cage, but you can really just place a portal in and drop a Optimesh bag right beside that interbody spacer, and it can be a very easy way to fix a pseudoarthrosis in those cases that are sometimes almost seemingly impossible to manage. Yeah, and I've even salvaged some pseudo cases like in Scully that I mentioned where, let's say, the patient's had a tendon pelvis, but they've had continued pain, and say we got some vacuum disc phenomena on one of the discs where there's some motion. You can even drop an Optimesh bag through a tiny little incision, and salvage your hardware if they haven't had a hardware fracture yet, to provide some anterior column support through a very easy approach. So those are really cool applications of the implant too that I think make it very unique.